Now we got it. Okay. Oh, thanks. All right, we're going to get started. Welcome everyone to this session from Neomedic. My name is Peter Rosenblatt. I'm a urogynecologist at Mount Auburn Hospital in Cambridge, Massachusetts. And briefly, just state who we have on our panel. We have Mike Kennelly from Carolinas Medical Center. We have Conrad Duncan from Ascension, St. Agnes Hospital. And we have Omar Duenas, did I say it right? Omar. From West Virginia University. And we're going to be talking about several of the products that Neomedic has and go from there. So this is the agenda for the next hour. We are going to talk about these three products from Neomedic: AnchorSure, which Dr. Duncan will speak about, which is vaginal prolapse repair, sacrospinous fixation. We're going to talk about BioSure, which was launched just last year by Omar, and that's a fascial autograft. And then we're going to, Mike is going to talk about Remix, which is the adjustable sling. We have a couple cases, and we really want to leave time for a Q&A. We do have a microphone that we can pass around. So now there are papers and pen, I believe, at each table. So if you have questions, it's probably better to save them for the end, and you can either stand up and ask, or you can bring those papers up to someone. We'll have someone. Okay. So just a little something about Neomedic. Neomedic's been around since 1995 in Europe, and they came to the US in 2009 with a couple products, and they've continued. You know, they're an international company, but this is one of those companies you see year after year at the meetings, like Augs and SGS and SUFU and IUGA and several of the other meetings around the world. And they are very committed to developing products for pelvic floor health. So, and you're going to be hearing about some of the products both today and here at the meeting. Some of the abstracts and presentations are about their products. They are based in Spain, halfway between Madrid and Barcelona, where they have engineers and they do development there. They build their products in Spain. If you look at their timeline of products, I became familiar with them back in 1995. That's when I started my practice. That's the year. I can't believe it's been that long since they came out with the Remix sling. And we'll hear about that from Mike Kennelly. And the rest of the products here, you can see there's the Remix Male, they have Needleless, which is their single incision sling. AnchorSure came out 13 years ago. And the only product that I'm aware of that is not available currently in the US is the Uplift, which it's a sacrocolpopexy with an anchor of some sort. But I think they're looking for, at some point, bring that to the US market. So first we're going to hear from Conrad Duncan, and there's a lot on here. He's a director of urogynecology at Ascension, St. Agnes, practices in Baltimore. I learned a lot actually from this. What a pedigree. Dartmouth College, Yale University School of Medicine, and he got his JD from Georgetown Law School and does a defense case review. I did not know that. And then the funniest thing in here, it's buried in here, I have to read it. After his training, he spent 7 years in the Indian Health Service, and then 7 years at the University of Kansas, where he was routinely yelled at by Kermit Krantz of Marcia Marchetti Krantz. Anyway, I think that's enough of an introduction, and we'll bring up Conrad.
Thank you. Thanks for coming. Everybody watching Zoom or Zoom-like, thanks for sharing time with us. The Krantz story is actually important because most of you have no idea who Kermit Krantz was, but MMK fame, he would one day he chased me down the hallway. He was 1,000 years old. He chased me down the hallway. God damn it, Connie. God damn it. What the hell were you doing in the OR? I had just done a laparoscopic birch. And it wasn't that it was the birch that bothered him. It was because it was done laparoscopically that bothered him. He just went off. And the residents are laughing their asses off at me, like behind me. But the problem is that embracing change, sometimes embracing different ways to do things can be difficult. You all voted off yesterday off the island on the balloon, the preeminent pelvic anatomist in the world. You voted him off first, okay? Which was pretty astounding because if anybody knows more about pelvic anatomy than Delancey, I don't know who that would be. So the problem with his talk is he didn't have the promotion that some of our other speakers did, and he didn't have the razzle dazzle. But what he was telling you, and if you read his article, it is very difficult to follow what he wrote in the 4-point Michigan suspension. I look at him like that's difficult. This product makes that procedure very simple. And it makes the concept of the sacrospinous ligament suspension very simple, and we can put it in your hands. Know your audience when you're giving a talk. I don't know you guys because you voted off Delancey. I'm like, The other thing is, some of you are here for lunch. Some of you are here to put your toes back into vaginal surgery. Some of you are trying to find out the best way to deliver a stitch to the sacrospinous ligament. In other words, you've already been convinced that's an excellent way to do things. As Peter mentioned, I do litigation. Right now I'm trying to defend a case where a patient died after, it didn't have to do with prolapse, but died after a robotic case, and the plaintiff's attorneys are arguing, well, there were safer ways to do things. Now that hasn't really hit us yet, but be careful. Vaginal surgery is still the safest way to do anything. Now we didn't talk about safety during the balloon, but if you want to be safe, go vaginal. Okay, let's get started. I have video we can do at the very end if we have time. We're going to run through slides very quickly so we have time for everyone to give their little spiels. Again, you know this. This was advice. The only FDA-approved anchor device with RTC studies. There have been about over 150,000. This is 2-year-old data. 150,000 anchors, and I believe still no mod reports. Right? Is that right? Am I correct? I've been using AnchorShore since 2016. I have the dubious honor of probably putting more than anybody. That's dubious because I'm old and I'm busy, and that's not the way things should be. I should be on a beach somewhere. So it's not as if I'm so great at it. It's just I've been doing it a long time with high volume. That's all. And here, therefore, I'm here to sort of explain my experience with the device. I've had 2 anchor extrusions. They were silk. I don't use silk anymore. And I use PDS. And my mean operative time, this is a very important point, lost in the balloon discussion. I can do every compartment, including a perineoplasty, with or without a hysterectomy, in about 2 hours. So when you're talking about, and I know there are institutions that have robotic teams that turn over in 15 minutes. I don't know where those institutions are, but you know, after 6 hours of robotics, doing your hysterectomy, doing your sacrocolpexy, and you haven't touched what, Delancey says is very important, which is your general hiatus and the rest of the vagina, you're going to kind of think that maybe the time savings is important. Why is it important? Not just for you, but for our patients, okay? This is the graph. You can see at the very end here, this is the size of it compared to a ballpoint pen. It's really small. The anchor. The anchor is made out of polyether ether ketone, which is used a lot in orthopedics. It's just a biocompatible plug. Just a thought. This is prolapse, and this is every single prolapse case that you do is this case. It may not be this far progressed, but again, in the balloon discussion, we're talking about suspending the apex, and I don't think I've ever met a significant symptomatic prolapse that was pure apex. So the whole discussion, and my panel may, this is a thought that we're talking about suspending the apex in the balloon discussion, and a lot of us in the audience are going like, and what about the rest of the prolapse? What about the rest of the defects that are either there or are going to be there? Very important to remember, okay? This can be used with massive prolapse. This is a lady with stage 4 colon cancer, and that's ascites. And she just wanted to have sex before she died. This is a case that was she actually lived 3 years after this. So this was stage 4 colon cancer, mets all over the place, nobody would touch her. This was ascites. She was tapped the day of the OR, and we got her fixed in less than 2 hours. The suture that comes on the device can be changed out to, how are we doing on time? That's not really running. Okay. The device that comes with a Proline, I switch it out, I use PDS. You can switch it out to Silk, Vortex, or whatever you prefer. And again, it can be used for the 4-point suspension, which Dr. Delancey mentioned. He needs to change his name for Michigan because who cheers for Michigan. But the issue is that 4 is better than 1, because in the old days, which Peter and I remember, everyone else is too young, but in the old days, we would get 1 stitch, maybe 2, up to the posterior approach on the patient's right side, because most of us are right-handed, and it took it off the colon. And that was it. That was all we did. Now we have a way to deliver a stitch to all 4 points, anteriorly, posteriorly, in minimal time. And we'll see it on video how easy it is. 4 is always better than 1, except for years in jail. And as one of the residents told me, yeah, and except for stupid people. I don't like stupid people. I said, okay. And it can be placed in ilicoccus fascia if you can't reach or identify the sacral spinous ligament. I don't, that's just a way to get the procedure done. Catherine Matthews' article talking about postoperative pain in the Green Journal last year. And this is actually from it said 2002, but I think it was 2001 this was done. And again, looked at our prospective cohort study at the device. And again, these studies are done with AnchorSure and no other device, no other anchor device yet. Post-op pain. This is a little disingenuous. I've gone back to 23-hour observations rather than same-day admissions just because COVID made me shift that, and I've kept that. Simply because the insurance companies don't mind that we keep people 23 hours. Most data on same-day surgery is somewhat disingenuous because some of that's just based on preference. But the reality is most of these patients go home without narcotics. Very rarely do we send anybody home with a narcotic medication. The real trick here, the thing to remember, is that the dissection to apply an anchor is literally the dissection of your finger width, where you do the dissection, palpate the ligament, take the device over your finger, and punch in your suture. Again, in the old days, we used Nebraska retractors. We had 2 or 3 of them in there, 2 or 3 residents. And I remember somebody crying yesterday about their hands hurting, and their back hurting, and their neck hurting, and that was why. We don't have to do that anymore. We can simply follow your finger, punch in the suture. It is literally that simple. As you know, Capio device advanced the concept from suturing, and this is an advancement from that. It's just truly tactile surgery. This is the Saffron device. It's just a comparison of the tips. Do we have any Saffron users in the room by any chance? Okay, so Saffron's another anchoring device. There will be a shift, Dr. Grants, there will be a shift to using anchor devices because we want to embrace the sacrospinous ligament as a true fixation point. And how do we deliver the suture there fastest and safest? This is important on this slide. The only important part really here, I think, is that the pull-out force for an AnchorSure is about 9 pounds. It's up 50 newtons. So newtons and pounds can be translated back and forth. So 9 pounds is about 50 newtons. Okay. 2.2 times whatever. The issue here is that the Saffron may have not quite enough pull-out force to surpass what is physiologically important, which is considered 25 newtons, or about 5.5 pounds in the body. And again, we're just looking here at the delivery of the device. That's a Capio device where you can endanger looping it behind the ligament or entrapping tissue within the device. The anchor replacement, this is not a very great picture because this runs parallel to the floor. You'll see in the video, if we have time to see it, that when you apply the AnchorSure device, literally you palpate the ligament, you put the device in, you stand it up. So when I apply it, it's perpendicular to the floor. It's truly resting on the ligament. There can be no mistake about where it is. It is so precise that you can obviously put it 2.5 centimeters medial, but you can also lay it on the lower edge of the sacrospinous ligament. It's a perfect placement based on your palpation. The way it sits and the beauty of the device, it gives you complete haptic feedback at application. So it's applied, you know it's applied correctly because you have a shelf that's solid. The ligaments feel different than any other thing. We, as gynecologists, call a lot of things ligaments that aren't. But this is a true ligament. It connects bone to bone. And when it's on the ligament, you know it's on the ligament. You deliver the device and it makes a pop sound. You know you're exactly in the right place. So it's a brilliant design. I don't know if that's accidental or if it was thought through, but it works perfect for what you wanted to do, and that is fixation of the suture. And I'm going to stop here on this. We'll move on and have questions. Remember, write your questions down now so that you don't forget, and we can collect them, and we'll have time for questions and answers afterwards. Thank you.
Great, thank you, Conrad. Next, we're going to hear from Omar Duenas, who got his medical degree in Mexico, and then did a urogynecology fellowship at UMass, right near me. He's now at West Virginia University and director of urogynecology, and he will be talking about BioSure.
All right, so thank you. All right, so who in the group here actually uses graphs? Perfect. So, excuse me. Of course, well, just a quick refresher, right? So a graft is basically any tissue that is being implanted in the human body. And this is a biological agent. And what is different from a prosthetic agent is actually that you are not using something that is synthetic. Of course, we have multiple different types of grafts, and possibly the xenograft is the one that you don't really want to do. Isografts is almost impossible to try to find one unless you have a twin. And for sure, we only have a couple of options here, right? So we have the allografts, and also we have the autografts. In these cases, of course, a lot of us probably we use autografts, right? It's a little bit interesting, right, for all the slings and what is happening right now with the mesh. I can tell you a little bit about how I started getting involved into this. Last year, I had a chance to go to the UK, where I stayed there for a few weeks, and I was looking things around, and I can tell you how much everything has changed after they stopped using transvaginal mesh. And when you think transvaginal mesh is not only your regular transvaginal mesh for products, it's actually slings. And this is something that completely changed the way that people, they practice urogynecology, as I feel that they went back in time and they're opening patients to do birches. Not too many people are offering laparoscopic or minimal invasive options to these patients. So I think this is something that, for sure, it will be just another tool in your toolbox and something just to think about, because New Zealand, Australia kind of follow the same pathway. I hope we're not in the same pathway, but this is always something that for sure we have to start looking in the forecast and just to kind of have a couple of options. Of course, you have maybe pay attention, and there are multiple different studies out there, the controversy about the use of the grafts, and not every single graft is the same, right? Just in the same way that not all the meshes are about the same, and it took several years or maybe decades until finally they realized that we have to use a type 1 polypropylene mesh. Probably it's exactly what happened here with the grafts. As Dr. Duncan mentioned, right, so the pull-out strength for an actiosaur is about 50 newtons. Here you can see that fascia lata is really strong. It's about 270 newtons. So it's probably one of those things that maybe that actiosaur is going to pull out before your fascia lata is going to come up. Compared to some other grafts, we have the human dermis, and certainly using others like rectus abdominis fascia, certainly they have a little bit less pull-out strength. Just looking into the array of the fibers, I think this is again very visual. We're not pathologists, but just in the way how the fibers are being distributed for all the collagen in fascia lata, this is something that is very different compared to using dermis. And this is probably something that is different in the studies. And of course, we don't really have that perspective data at this time. But I think this is the time that we have to start looking into this, and maybe it's people that have been looking into the wrong graft, and maybe it's time just to start changing that. And you're using or considering using this, maybe fascia lata is probably the best next step. A couple of the critical aspects of this is about the ECM or the extracellular matrix. right? So it's basically the ECM is everything that is left behind in the tissue after the cells are being flushed out. DNA, all the cytoplasm, everything that you learn in high school and also in the undergrad is being washed out until we have that ECM that is going to work as an scaffold for those fibroblasts to finally create the new tissues. A couple of things here that are different is the way that how most of the grafts are being processed. I'm not talking about autografts, I'm talking about the allografts. In this case, whatever is in the market, the majority of the grafts are actually processed using gamma rays. And everything that is put into radiation, right? If we have been taking care of patients that they suffer radiation for cancer, we know the quality of that tissue. And the same thing happens when they use the similar gamma rays to sterilize this material. And I think this is what is so different from BioSure. They use this supercritical CO2 process. Just not to be very technical, but the supercritical aspect is when a certain material, in this case the CO2, at certain pressure and certain temperature, just reaches that state that is semi-gas and also semi-liquid. And literally just flushes everything out from that ECM and dissolves literally the tissue, just leaving that ECM intact. If you think, okay, this is safe or not, well, probably if you have ever done caffeine or decaffeinated products, maybe you already were exposed to this supercritical CO2 process as they use it for decaffeination. So everything is moving out from using chemicals to now using this process in the grains of coffee. So this is something that FDA feels really safe about that. Couple of the advantages again for this type of material, of course, is good tissue preservation, intact fibers, the tensile strength, and also the stiffness. This is something that once you hydrate the tissue, you can actually feel the difference compared to some other grafts that are available. They can come in the market in two different sizes, 7x10 and 2x10. Couple of ideas and something that I actually saw out there, what people are using. Just to think about, this is actually from Augs in 2020. This is the joint report of terminology, and actually they consider that for using grafts or using mesh for this type of repairs. And just a couple of your pictures here from this model that I have. I know that some folks are doing some sacrospinous hysteropexis, and you only use sutures. I'm just wondering what happens with that bridge that we have here. When typically they teach you how to do sacrospinous, the first rule is no bridges, right, when you're tying those sacrospinous. So it's technically impossible just to leave a bridge there because we have the distance between the cervix and those spines is about 3 to 4 centimeters. So a couple of ideas is how people they have been doing this is something that I learned overseas and also here in the US and also in South America. People are even using mesh to do this. They call this an apical sling for hysteropexis. And for sure, probably we don't have a very robust data out there, but this is just something just that it could be out there for you as another tool in your toolbox, right? So we have this BioSure that is being attached to the cervix, and now you can actually reach those spines in a better way. Just for those patients that maybe they have a short vagina too, this can be a great option just to augment that tissue. For those patients that maybe they have more weakened cervical fascia, also that can be the way that you can reinforce this. Just instead of using the apical portion, you can actually stent your graft, and this can be anchored close to the bladder neck. Couple of the evidence, as I mentioned, well, the evidence is all over the place, but I think the problem is just all the studies that we have are really heterogeneous. And especially a lot of the studies that they have been done are with products that they are not even longer in the market. Same material also can be used for stress urinary incontinence. I don't know who does pubovaginal slings. Yeah, perfect. All right, so, and again, right, like of course, slings, synthetic meteorital slings are really popular, but sometimes when we have those patients that they can fail or they don't want to use any mesh, what are your options, right? So you can do a birch, or you can do one of those slings. Of course, you can do an autologous rectus fascia sling. The problem that I see here sometimes is just the pain, right? The bigger the incision, also the higher chances for you to develop a hernia. So there are a couple of other ways that you can do these, and it's also harvesting your own fascial lab that way. It's technically difficult. Not too many people they have the training, and of course, it's also painful. There's actually more evidence out there for the use of these kind of grafts for stress urinary incontinence with randomized trials. So it's actually really safe, and it's something that you can offer to your patients. Other applications, this is something that is being used in gender affirmation surgery to kind of wrap around those fake corpora and the penile prosthesis, and also for the vaginal fistulas, and also for urethroplasties. So this is a material that maybe us as urology we haven't used that much, but when we start looking with our colleagues, urology especially, they do reconstructive surgery, they use quite a bit of this material. So something, and maybe the evidence is not really robust, but because, you know, it doesn't mean that people are not doing it. And I think the idea here is just to start collecting more prospective data and kind of show how this works. A couple of things, sometimes for technicalities, right? So you're gonna say, how do I get the pay, or how the patient actually, the insurance pays for this, is that you have to report when you're doing the repair that is actually a truly indication for the graft, right? In these cases, you can use this cause of incompetence or weakening of the pudovesical cervical tissue or of the rectovaginal tissue. And I think that's all that I have.
All right, and finally, for the presentations, we're going to hear from Mike Kennelly, who's a urologist and FPMRS specialist, and is currently at the Charlotte Continence Center and the Carolinas Medical Center. And he's got a huge list of accomplishments, past president of so many societies. And he's going to talk to us about his experience with Remix, which has been probably over 20 years or so. No,
not quite 20. Thank you. Well, it's a pleasure to be here, and we're switching gears. So really talking about stress urinary incontinence. How many people have actually used the Remix for stress incontinence in their own practices? So we've got a handful of people. So I'll kind of give you a little bit of background, at least from my perspective, of where things are at. In my careers and many of the careers of the people on the panel here, we've been searching for the ideal surgical treatment for stress incontinence. We really haven't found it. Probably the closest thing is the midurethral sling that achieves all the parameters we're looking for on the right of the screen. But one of the difficulties with all of these things is that it is basically a intraoperative tensioning, and you're done. We have no ability to modify them afterwards. So having something that is potentially post-operative adjustability or down the line could be an option for things. You heard from Rebecca Rogers today, the realities of stress incontinence. What is our success rate? It depends what you call success. They fail over time and things, whether that's the TVT, the autologous pubovaginal sling. People, if you follow them long enough, over 10 years, start to get down into the 30% range. And if you stay in the same location in your practices, which I hope you do, you will have the patients coming back to you. And so kind of my journey with things is I started out in the late 80s doing autologous pubovaginal slings. That's what I was trained on at Michigan with John Delancey and the others. Then I started saying, well, in 1997, what about the biological slings? Because no one wants the incision within that area. And there's very different biological slings and how they're processed and manufactured and et cetera. Then in 1999, I started looking into synthetic slings. So we had the retropubic synthetic sling. We went from the top down to the bottom up. We had the controversies in that area. 2002, we said, well, let's try something different, the TOT. Let's do the inside out and the outside in. And then as it moved along in 2007, we started with single incision slings. Well, everything's trying to get things better over time, but then as you know, the FDA with the pelvic health process came forward. 2014, we lost our meshes that also went out with the graft materials. And that's when I started saying, wait, we need some other alternatives. And that really opened the door for another sort of tool in your chamber. So these are the tools in my chamber right now. You know, autologous fascial slings, retropubic synthetic slings, single incision slings, and remix sling in addition to bulking agents. So this is, we don't have time to go through the study, but basically this is one of my patients. 63, 2012, she had TPHA&P, Solic sling. She had voiding dysfunction after the Solic sling. She ended up trying alpha blockers, PT, wasn't really effective. Eventually had a sling release. That was in 2014. Of course, stress incontinence came back. She had an autologous sling, did well for a while. 4 years came down the line. Lo and behold, she's got recurrent stress. You evaluate her bladder stable. She's got scarred there on the urethra. So what are your options? This is in 2018. Our bulking agents that we have today were not in 2018. So what would you do? These are things that you're going to have to be faced with in your own practices of realities. What are you going to do next? So I think the keys to success regarding any surgery you decide to do is the 3 Ps. Physician expertise, get trained on the area, have product performance that you know the device in and out, and have patient factors that are ideal. When you're talking about the remix specifically, there's certain nuances you've got to kind of look at. The device, as you said, it was a European approved in 2001. In the United States, it was 2009. It is in a small mesh footprint, so 35 millimeters by 12 millimeters. It has proline sutures on that area. It has a varotensor, which is the regulator adjustment, and then a manipulating tool. The nice part about this area is that it does allow post-implant adjustability. The other thing that you're seeing is this is a full circular sling. It's a fixed circular sling. And what you see on the right is with above the abdominal rectus fascia, as you cough, you're going to get dynamic mobility. When they cough, the rectus moves up. It's pulling up. And that's the beauty of a full circular sling. So when you do that, a couple of nuances. The first part I would say to have key success, you've got to pick the right patient. This is not easy for the patient, it's not easy for you, and it's not easy for your practice because about the post-operative adjustability. In my practice, you got to have the patient buy-in, tell them that they do need to come in afterwards to get adjustability. It's not like you're one and done. So patients need to do it. And then you have to decide how you're going to do adjustment. Are you going to do it right afterwards in the PACU? Are you going to do it as a 23-hour observation? Are you going to have them come back to the office? Do you have schedule in your office and people there to do it? So there's some logistics you've got to kind of look at. Intraoperatively, the things that I would kind of do is the same that you normally do, except make sure you're shaving suprapubically. We tend to put IO band over the suprapubic area, trying to minimize the risk of skin issue to it. But otherwise, it's really the same key steps that you're using for a retropubic sling. The difference is suprapubically, there'll be a 4-centimeter incision going down to the rectus fascia. As you pass the threads up, you're going to have a varotensor. The varotensor that's in that area actually has the ability that you're putting the sutures through the side part of it. You're going to lock it into place. You'll then start turning the spool clockwise to get down about 10 centimeters. At that point in time, you just easily turn it down to about 3 centimeters above, put it in the rectus fascia, irrigate with antibiotic irrigation, and then close the area. So a patient then, when they come back to the office, or however you do it, you just what is here. I'll have the patient fill them up, usually 250 to 300, have them stand, have them cough. If they're leaking, you just turn, usually 3 turns at a time, and then have them cough some more. If they still do it, keep turning. You will notice a sudden stop. When it stops, like, oh, that hit it. I have patients then sort of go outside, walk around, go up and down the stairs, and then at the end, do a voiding trial. So do a Euroflow in the office and PVR. The key about this is when the patient feels comfortable, you're done. And when it's comfortable, it's super easy to take out. There's a little screwdriver that goes in, turn it a quarter turn, and it slides right out. And then just put a steri strip over that area. So who are the candidates in my mind who I would sort of look to these type of people? Certainly someone who's had recurrent stress urinary incontinence and immobile urethra, someone who has chronic sort of coughing, that someone really has COPD, that you really need that full support to that area. I also use it for people who have underactive bladder, where you just gotta find that right tune so you don't make them sort of over the top. Index SUI patients, I certainly use it also if that's what they want. I think for the patient, it revolves a little bit more time for them to do it, but we have used it in that regards. Who do I not use the remix sling in? Certainly diabetics. I think your risk of infection is a little bit higher in this regard. Immunosuppressed patients, active UTI, of course, you're not going to do it at that time. If you have intraoperative urethral injury or urethral diverticulum that you find, I would not put a synthetic. You may use a biological in that situation. There's some adaptations to the remix that we kind of switch to biologicals. at that point in time. So I think the difference between an autologous and this is that basically it's easier for the patient. This is a much easier recovery for the patient, less discomfort. The ability of not needing to catheterize, you have someone who's fearful of intermittent cath or suprapubic tube or prolonged Foley, this allows them to be involved and they're part of the decision process. Surgical time is much easier because it's very quick. You do it under general anesthesia. You don't have to worry. Well, what about the evidence? I'll quickly go through this because I know Peter wants us to move along. But the report evidence, these are 7 reports that have had over 2 years of data, and 3 of the reports over 5 years of data. Everyone's issues of success is different, but you can see success based on a lot of our cough stress tests are pretty high. Interesting report was this one, 205 patients that they followed for 7 years. Interesting that I was looking at is, well, tell me how many times you have to redo this. So 88 times, which is nearly about half over a 7-year period, there was a readjustment that's being done. Majority of the adjustments were actually tightening it. When you got more than 2 tightenings, that was about 6% of people. 3 tightenings was less than 3% of people. But people, if they want something, the adjustments are easier because it's a local anesthetic, dissecting down right to the varotensor, putting in a new sterile stick, closing it up, and you then repeat the same process of adjustability. But patient engagement is key. As far as adverse events, infection is probably the biggest thing. So our paying attention to sterile technique, putting implants in is really important. Other reports assert about voiding dysfunction. Once again, because you have control when the patient's away, all their activities, you can control the tension. If you go a little bit too tight, you can loosen it and have that. And it's shown it's been function there. And detrusor underactivity. A lot of times we don't know what we know until after we put a sling in or et cetera, and they can't void. And that becomes very difficult. So this has the ability for you to have a little bit more control, a little bit more comfort in tending to do it. That was my 10-minute timer, so I'm going to end with the last 2 slides. So from a surgical perspective, it's easy if you already know how to do retropubic slings. Same process to do that. I think if you have a patient who really wants to be involved in their care, they want to be awake, you want to make sure it's done right because they haven't had a great outcome during the first time, this is really a good option to do it. And long term, over the 7 years which I've been doing this therapy, yes, we have opportunity to come back and it's simpler on the patient because it's still outpatient procedure. So I think for everyone who manages stress urinary incontinence, I encourage you to have several things in your toolbox. You saw my toolbox of what I have because we use different things for different patients for the right time. I think you can definitely get cure within that area, but it's always cure versus retention. You're trying to find that fine balance of things. And I think it's nice to know that you don't have to go back in after someone's had several slings in the under the urethra to go back. To do something above is easy in this regard. So I thank you very much.
I think Mike brings up a really good point, that it's important to have many different tools in your toolbox. I think Duncan brought that up as well. Conrad brought that up as well, because, you know, look what happened to our colleagues who were totally dependent on transvaginal mesh, right? And it just got, you know, taken away from us. And, you know, so I think it's important to, you know, birches, preferably laparoscopic, pubovaginal slings, synthetic slings, adjustable slings. Mike, a quick question for Mike. Would you ever consider doing the adjustment or in the future in the office setting?
So the answer is,
Sorry.
Currently right now, that's what we do. I originally had a 24-hour observation, and that was nice because it was easy to do it the next day and they're awake and then they go home. But now when COVID came through, everything's outpatient. So we just put them in. I tried to do it in the recovery room, but they're through the outpatient surgery center. They want to move them out. So they don't have the time. So they basically go home. You don't have to worry about retention because you're leaving it super loose. I'm telling them they're still going to be wet. And so when they come the next day, it's easy adjustment. They have the ability to do it. So we do it in the office.
Okay. And over the years that you've been doing this, is there anything that has changed that you've learned from your experience with that type of sling?
Well, as with anything, the more you do of something, you're gonna find the little tweaks and the nuances of where things are at. We have training programs who are training others to do that. One thing that I would state is that if you place the sling vaginally in your clothes, as you're pulling up on the suture, be careful that you don't pull up too tight. You actually want to still have things loose underneath the urethra. And there have been times that I've left a loose 3 centimeter gap, and lo and behold, the person's totally dry.
Yeah.
And I've never had to adjust.
Yeah.
I'm like, oh my God. And it's probably because while we were pulling the sutures up, we accidentally lifted it against the urethra in a snug location.
Also, any issues, maybe this doesn't come up in the Carolinas very much, but with very thin patients, with the very tensor?
Right, so you can actually put it under the rectus fascia above the muscle. Or some people do, but I do actually have thin patients, so I use it on, but I show them the device. That's the other thing, get patient buy-in from the beginning. So we show them the device, this is what it is, and also be careful, don't put it too close to the pubic symphysis. When you make your incisions therapeutically, kind of go above, you should rest above and not rub on the pubic symphysis area.
Okay, thanks. So, yeah, sure.
So the mechanism is similar to a pubovaginal sling, is that correct? In that sense, that why is it not more closer to the bladder neck as opposed to the urethra? Because
Can people hear the back?
So the question is, towards the bladder, the reality is, urethra is about 4 centimeters. These are 15 millimeters. You're not putting it in the distal urethra. They're all relatively within the same area. And everyone's urethra may be a little bit different based on this, so urethra seal component to it. But what you're tending to do, because it's a full circular sling, it's locked in fixed. And so you have the ability to, every adjustment you do, you will get it tighter and tighter at some point.
So we'll go on to a couple case studies. The first one, and I want to get everyone's opinion about this. 65-year-old multiparous woman presents with uterovaginal prolapse for several years, worsening recently. She has mixed symptoms of incontinence, stress created an urge, no hormone replacement, has not been sexually active due to embarrassment from the prolapse, but would like to be. Prefers to avoid a vaginal pessary. On exam, she has moderate atrophy. Her uterus is small, mobile, no adnexal masses, and her PVR is 85 cc's. This is her POP-Q, so leading edge is the cervix and the anterior vaginal wall at +3, but she's got significant posterior wall prolapse. What would be your, well, before we get to treatment, workup, evaluation, any thoughts?
We can feel like our sexual questionnaires for these patients are disingenuous. I mean, it's ridiculous to say much about spending time on question sexual questionnaires when your point C is +3. So first thing I want to remind everybody, it's very important post-op, but pre-op, you really don't want to spend much time on that. It's maybe flying against the rating on it, but and just brief about hysterectomy versus uterus removal, conservation, patient choice. The elephant in the room is that your insurance company will not allow you to remove the ovaries during a transvaginal move, but you're also removing the uterus. Now we've gotten away with it with some venoes to do BSOs because we have a small cyst on a 55-year-old woman. We get away with it. I'm not sure how we're going to push that envelope because the question isn't whether or not they want to take their uterus, whether or not they want to keep their ovaries in a lot of patients. And I think that conversation has to that. But for this patient, uterus removal, non-removal doesn't matter. I still do a transvaginal repair. With it, the important part is that there are components here that are not addressed, laparoscopic abdominal, that's general hiatus. And this woman also deserves to have all that corrected too.
Just while we're talking about it, yeah, can I do that? Would you do an anterior or posterior approach to the ligament? Was that your question?
I do both. I do a 4-point, and I do anterior approach and posterior approach. And unlike Dr. Lindsay, I do a flush attachment to one side. You can't do a flush attachment to both sides, or else you fan out the top of the vagina. And when you leave the cervix in place, you're putting those sutures into the cervical tissue, posteriorly and anteriorly. Those sutures are about 3 centimeters apart. So see if you can get that flush to both sides is ludicrous. So I do a flush attachment to the right side, a bridge attachment to the left side. And with graft material there, it takes care of all that. And make sure that graft material posteriorly is underneath the cervix, that they keep it, and it's attached to the cervix to prevent any deeper interosseals. And anteriorly, I still do 4-point fixation of the graft, like distal, anterior fixation points into the operator, the Prince muscle, also with an anchor show.
So the question I was having prior to, time extensions, if you're safe side running, you're also repairing hand and both the compartment.
Absolutely.
Thank you. Any more thoughts about this?
Not integrating the mid gut vaginal repair into your apical repair. Like, that means like you're not including the endopelvic vagina, the anterior compartment, into your apical suspension sutures.
Not immediately, but because I will do a grafting material anteriorly, it will cover that entire anterior wall. And the grafting material will go darkest tendon to darkest tendon. Distally, it'll go to the bladder neck at least, and sometimes the mid-urethra, and proximally it'll go to the anterior cervix, so covering the entire anterior wall. I do not rely on the patient's fascia what here may or may not have, because there's already, we have an anterior defect, we have some fascia defect, whether it's perivaginal or central. We think we can tell the difference, sometimes we can't, so I replace it with a graft kit.
Any other questions about that case or questions about the presentation so far?
You ever, one more thing about anchor shirt, do you ever comment on putting 2 sutures into the anchor so that you only pass it twice, 2 anchors, so 2 sutures each to get your 4 sutures?
I personally do not. Again, the approach sake of spine is from an anterior approach and from a posterior approach. And those 2 placements are a little different.
Yeah.
Pretty much it's very close, but they're just different approaches. So the dissection of the perivertebral space and the dissection of the perirectal space are very different dissections. But I don't use 2.
Also, the new harpoon for the anti-sure also comes with 2 sutures, and you can actually, with only 1 harpoon, you can actually have like almost like 4 sutures going out of it, so it's sort of more mass.
Okay, let's move on to the next case. We have a couple more minutes left. This is a 78-year-old multiparous woman. She's had a vaginal hysterectomy, AP repair 20 years earlier, and now she has recurrent vaginal prolapse and urgent continence. She doesn't report any stress incontinence. She's tried a pessary in the past, but found them uncomfortable, and she's got severe vaginal atrophy. POP-Q shows leading edge, again, anterior and apical. I think it's important here to look at her total vaginal length as well, and how does that influence. But I'll tell you what, before we go to treatment again, what would you consider important for a workup of this patient?
I think Peter, you just mentioned, right, like the DBL is probably kind of the most important aspect in this case, right? So, with transvaginal approach here, maybe the only option is an either oxygenous suspension that we're gonna know that probably is gonna cause a little pain and maybe suboptimal, as the procedures is not as strong as the spinal statement. So I think this is the time that probably using a graft just to kind of just give you more elongation of that wall will provide you better suspension.
I was going to chime in. It's important to note in this particular exam we have a huge posterior defect. This is a huge interosseal. It's a true hernia. So a hernia we deal with, right? So hernia's definition is the bowel contact with skin without intervening fascia. So this by definition it requires grafting. And I would do a posterior approach on this and make sure the vaginal length improved.
Preoperative estrogen?
It's great if they do it, but I don't think that they have enough time to make a huge difference with preoperative estrogen. I think it's great. I have to say I don't know. I can't tell that it makes a huge difference.
I think a little trick, by the way, that I've done in my practice is, so I don't really agree. I'll tell you why. Patients want to get this. So they've had it for like years, right? But they want to get their treatment tomorrow. And I'll say to them, I'd love to operate on you, and my schedule I can book into December. But we need 2 months of vaginal estrogen, and because I'm booked. Then they figure, okay, that's when I'm going to do it. I'm not really putting them off because of my schedule. So that's what I use.
I would say one of the other sort of tricks that I do in preparation for a sacred spinal ligament is periodically when I have the patient at home when they're lying in bed, just to try to do, leg stretches, knees to chest. Try to stretch that out, to decrease the risk for any post-operative discomfort. The beauty of the anchor shirt clearly is by penetrating through that you're just splitting the muscles. You're not actually putting a suture around in time, which could cause ischemia to that muscle, causing discomfort. But even so, some people have discomfort with it. I typically would say, well, were you doing your stretches? Oh, I forgot. Okay, well, it'll be fine.
Right. But by the way, and I don't know if you presented, I don't know if I missed this, but depth into the ligament?
I forgot to mention it, it's virtually impossible to go through, ligament.
Okay.
Depth of penetration is 1.1, it's 11 millimeters, so it's designed so you cannot pass it through the ligament. That's part of the design.
Preoperative urodynamics.
I tend to do them when a patient is presenting with stress incontinence, but I have found that all bets are off. In other words, we do the repair, our most common issue is urinary retention. And it's not predictable. So I don't do much in terms of preoperative evaluations, they just don't pan out to be meaningful. I do the repair, I do it the same for everybody. I do firmly believe in intraoperative grenade tests, so I do that on everybody. It's markedly positive at the time I'm finished with the repair. I will do a visual sling biological.
Oh, I was going to ask, did you do prophylactic slings?
I do not, unless the grenade test is marketed.
Oh, okay, so you preoperatively.
If I put 200 in there, do this, and they leak, I will put a sling.
Right, but-
Even when I suspect they're going to have, when we straighten out the bladder from this to this, we are
Yeah.
setting up for condoms. Even in those cases, I'm shocked how much retention we have.
One of the key things in using a biological graft on the anterior compartment, pay close attention to where that graft is coming across the bladder neck. If you actually elevate it too much on the operators, you will create an intrinsic sphincter deficiency. So I usually make sure that it's lax, and even if you tied it, you don't want to loosen, and you relax the incisions, just at the bladder neck, you kind of let that lax a little.
Any other questions from the audience? Well, since I made up this case, sure, she is.
And you have to be careful, because let's say she's not. Are you gonna offer ovopaesis? Because again, you're making sure she's never going to be. And that's a problem that we have with the concept of preoperative sexual evaluations. Right. And the procedure with an anchor short, in terms of speed and safety, you're approaching ovopaesis. Ovopaesis is not free lunch. That's not. And they're not as simple and as benign as we'd like to think they are. Getting an anchor to the sacral spinous ligament, let's say you just want to do one posterior and get that up to put a graft in, you are doing it faster than you do in both places.
All right, well, thank you all for attending, and thank you for the panelists, and please feel free to stop by the Neomedic booth. Thank you, John. Great job. I can't believe we actually got through that. Yeah. I think it's great. Yeah. Sorry about that.